Okay, so I have Lily Potter, who's a 23-year-old female that presents to the clinic for evaluation of right third finger pain after diving into a lake yesterday. The patient does admit to hitting a rock when entering the water, which resulted in right finger trauma and pain. Patient describes the pain as a throbbing sensation and currently ranks it at a 6 out of 10. Patient says the pain is worse when she moves the finger, but is improved with ice and immobilization. She denies using any medication because she states that the pain is bearable at this time. She does have associated swelling, bruising, and tingling that is localized to the palmar aspect of the right third finger. She denies numbness, weakness, radiation of pain, as well as denying wrist pain and hand pain. She did also sustain a small abrasion to the lateral aspect of the right third finger. She did wash the area appropriately after the injury, and she denies any redness, any discharge, or any increasing pain over the abrasion. The patient states that her tetanus is updated, which was done in 2017, and she denies history of previous finger injuries. The patient's medical history is not pertinent at this time, but she is healthy. She does take a multivitamin daily, but denies any use of prescribed medications. She does also have a penicillin allergy as a child and is therefore unknown of her reaction. Patient's family history was also gone over, but is not pertinent at this time. On physical exam, the patient's vitals were normal, within normal limits. The patient was sitting comfortably holding her right hand. It did appear that she was in no acute distress. Her skin was clean and dry, and I was able to appreciate the small abrasion that she noted. It was about 1 centimeter. Again, it was on the lateral aspect of the right third finger. There was no surrounding erythema, warmth, or discharge, but there was bruising noted to the palmar aspect of the right third finger. The patient's heart was regular rate and rhythm. Her lungs were also clear to auscultation bilaterally. On musculoskeletal exam, she did have tenderness that was noted to the distal right third phalanx. She did also have decreased range of motion at the third DIP joint to both flexion and extension, secondary to pain, but she did have normal range of motion to both the PIP and MCP joint. She didn't have any tenderness in the wrist or metacarpals, and there was normal capillary refill. She did mention that she had subjective tingling to the distal third of the finger. However, on exam, no numbness was appreciated, and the right third phalanx was distal neurovascularly intact. Patient also had normal 5 out of 5 strength in the entire finger. Again, the capillary refill was normal. For my medical decision making, my differential diagnoses included right finger fracture, right finger sprain or strain, possible right tendon rupture, and finger abrasion and finger contusion. So I did order an x-ray of the right third finger, which showed a non-displaced fracture of the third distal phalanx of the right hand. The growth plate was intact, and the radiologist also noted some mild edema that was noted, but no deformity. So my diagnoses included a right third distal phalanx fracture. My plan is to place the patient in an aluminum splint for immobilization. I also plan to instruct the patient to return to the clinic in about 2 weeks for reevaluation. I did educate the patient that normal fracture healing is about 6 to 8 weeks, and that she can use the aluminum splint throughout the day to protect the fracture, but that she can actually remove the splint for comfort at nighttime. Patient isn't using any pain medications at this time. However, patient was advised that if she should develop pain, to either return to the clinic for reevaluation, or she could also advise she can use Advil 400 milligrams every 4 to 6 hours as needed for pain. She was also told to take the medication with food and was instructed not to exceed 2,400 milligrams per day. My second diagnosis is a 1 centimeter finger abrasion to the lateral aspect of the right third phalanx. I instructed the patient to keep the area clean and dry. I also plan to reevaluate the abrasion in about 2 weeks when the fracture is rechecked, and patient was advised to return to the clinic sooner if she should develop redness, warmth, or discharge. And again, I educated the patient on the plan, and she voiced understanding and is in agreement. Is there anything that you would add?